Welcome, everybody. I'd like to start by having everyone briefly introduce yourselves and tell us what drew you to diabetes care specifically, and what does your day-to-day role on the diabetes care team look like? And I'll start. So my name is Jennifer Goldman. I'm a professor of pharmacy practice at the Massachusetts College of Pharmacy in Boston and director of cardiometabolic services at Welllife Medical. And I've spent 3 decades in ambulatory cardiometabolic care because diabetes affects virtually every organ system. And my role is really direct patient care, but teaching future pharmacists and physicians and physician assistants and educating clinicians across the country. And my passion is helping translate evidence into practical care that improves patients' lives. So why don't we go to Kristine? You're next on my list across.
So I'm Kristine Batty. I am a diabetes nurse practitioner and have been specializing in diabetes for over 20 years. The reason I chose diabetes is dating back to my grandfather, who had type 2 diabetes so many decades ago. And then I was diagnosed with type 1. At that moment, I knew I wanted to be a diabetes educator, as they were called in the past. I am now a certified diabetes care and education specialist. My day-to-day role is very interesting. I work through the University of Maryland Medical System at one of the community hospitals, and I have a split role where I assess the high-risk patients in the hospital and who have been treated in the emergency department. I look for, new complications, new medications, elevated A1C, hypoglycemia, and then I stratify their risk and help bring them to their post-discharge care. My other half of my job is we have started a diabetes specialty clinic in our transitional care center here at BWMC, and I am the nurse practitioner there. We have done great work serving a very vulnerable population.
Excellent. Caitlin?
My name is Katelyn O'Brien. I'm a clinical pharmacy specialist and certified diabetes care and education specialist. I work in an adult endocrinology practice in a health safety net hospital. And my role on the diabetes care team is to help provide education for patients onboarding to technology. But also, as a pharmacist, I have a collaborative practice agreement, so I'm able to start and adjust medications and help patients get on the right medications for their cardiorenal metabolic conditions, and also kind of adjust insulin delivery devices and technologies once I've onboarded them. So I'm also a certified pump trainer, and I see patients for different visits. So medication management, starting technologies, technology setting changes. I'm also available for handoffs or walk-ins on certain days of the week. So sometimes real things come up in real time, and we have that structure in place as well that I can offer open access for urgent issues that may arise, or urgent things when people walk into the clinic to get care same day.
Thank you. Natalie?
Hi, everyone. My name is Natalie Bellini. I'm an assistant professor of medicine at Case Western Reserve University and the program director of diabetes technology at University Hospitals in Cleveland, Ohio. I am a nurse practitioner, and I work collaboratively with a whole team of advanced practice providers, physician assistants, pharmacists embedded into our primary care, as well as our endocrinology practice. With the endocrinology team, the physicians, the fellows come and visit with me and learn how to operate on technology. I see patients in the clinic every week. So it's a really different and kind of a diverse role that I've developed for myself here in Cleveland, Ohio.
Awesome. Diana?
All right. Well, glad to be here. I'm also an endocrine clinical pharmacy specialist and a CDCES. I'm at Cleveland Clinic, and I'm also have some roles. I'm the co-director of endocrine disorders in pregnancy and director of education and training in diabetes technology. Really, I do a lot of the similar things that Caitlin does. But I especially see a lot of patients in pregnancy and help get them on technology, CGM and insulin pumps, as well as adjust settings throughout, and kind of try to come up with creative ways to deliver education related to diabetes technology. And I'm going to back up actually to, I think one of your first questions was kind of like, why diabetes, like how did we get here? And I even want to back up to why pharmacy. So I love medications, and that really came because I saw the power of how medications can help people when I was young, like in high school. And then diabetes was really, I saw my professors were doing similar things to what you're doing, Jennifer. And I was like, wow, they are able to help so many people. And I had the opportunity to participate in health fairs, educating on diabetes. And I thought, wow, if I can even help people as a student that knows so little, imagine what I could do if I specialize in this and have more knowledge. So here we are today.
Looking around the panel, we have pharmacists, nurse practitioners, and diabetes specialists spanning different practice settings in academia, community health, and academic medical centers. Before we dive in, how would each of you describe what makes the diabetes care team unique compared to other areas of medicine? And what is it about diabetes that requires this kind of team approach?
So it's a great question. I think diabetes is so much more than just glucose, right? We're addressing the whole cardiometabolic renal conditions. And because of that, we really want to have a team, right? And so I'm fortunate to work as part of a big team. We, in addition to pharmacists, nurses, nurse practitioners, dietitians, we also have exercise physiologists and social workers and clinical psychologists. And I think it's because there's so many components of it, right? There is the physical activity, there is the healthy eating, there is the whole psychosocial of, oh my gosh, this is a chronic condition, and all the things we're asking people to do every day, and that's really hard. And then also we know that diabetes can increase a person's risk of cardiovascular disease and kidney disease, and so it's really important to address those as well. And so I think for that reason, having this whole team and working together is so important. And every person with diabetes should have access to a team.
That was such a great answer. I loved that, and I think that one of the things that you make very clear is diabetes is one of the most team-based areas in medicine. So success really depends on medication management, education, nutrition, technology, behavior change, and long-term follow-up. So really no one clinician can do it alone.
I echo what Diana said and what Jennifer said. It's such a complex disease. And I think the team approach really does allow us to support people with diabetes with the burden that the disease carries or gives people, provides people. I think that the team really does help support all the aspects, like Diana said, exercise, food, pharmacy, vulnerable issues such as affordability of medications. So that will help people reach their health goals.
And I would probably close after you both so candidly and vividly like this is what we do every day, right? We see this every day, and every person is different. I think with diabetes, there's a couple of things. One, it never goes away. So the person that we're seeing in front of us has a vacation next week, or has a birthday, or has a holiday, or wants to fast, or wants to do whatever they want to do. And part of our job in this integrated, diverse network that we are working in helps we as clinicians are helping that person decide, look, a dietitian might really help here, an exercise physiologist might help here, you're struggling mentally, so let's help you with some psychosocial support. Let's help you. I mean, you guys, I order vegetables. We have a way to order vegetables through our electronic health records to get someone access to more fruit and vegetables. So it's not just one thing. It's not just, I can keep your glucose at 100 if you never leave this exam room. It's how do we help people thrive with this disease that is all encompassing? That is every time you eat, every time you exercise, every time the planning and around that. That's where that team-based approach comes in. How do I help you? Oh, you're having side effects, or your kidney disease is getting worse. Can I send to pharmacy? Can I help you with a patient assistance? There are so many different parts of it that if we don't work as a team, none of us could do this alone.
Exactly. And I think when I brought up earlier that I have these same day or urgent open access appointments, life happens and things happen. You can get a COPD flare or new steroids. And, sometimes in certain health systems, you can't see the doctor for 3 to 6 months. And so or you can say you're on steroids today, figure it out. So having an educator, diabetes care and education specialist, someone who can help in the moment when a life event happens. They're going on vacation and they forgot to coordinate, bringing backup supplies and now they're out of something. Being able to help in the moment and support the patient when life happens, I think is so crucial. And that could be, like you said, a nurse, a pharmacist, and a diabetes care and education specialist, a dietitian. And so I'd like to point out that all 5 of us do hold the CDCS credential. And I think that's worth pausing on for our audience. Can someone walk us through what that certification actually means, what it represents for a clinician, and more importantly, what it might signal to our patients?
So, when I started out in ambulatory care, I was doing family medicine and primary care, and wasn't really specializing in anything. But we're talking 30 years ago. So it turns out, one after another, all the patients that were being sent to me for drug therapy management had diabetes. So after doing that for 5 years, where my schedule was just packed with patients, it was such a need. I said, well, I think I should pursue this particular exam to become, at the time it was CDE, because it really just represents advanced expertise in diabetes education and behavioral change and technology and patient-centered care. So for patients, it really signals that this clinician has specialized training to help them successfully live with diabetes. So I wanted to really just make sure that my skills truly partnered with patients in managing their disease every day.
I love that idea of I've, as a clinician, have taken extra time to make sure that I understand the entire gamut of diabetes, whether you present to me with type 1 diabetes, type 2 diabetes, MODY, gestational, pregnancy with any of those, post-pancreatectomy diabetes. We become experts in our field of diabetes, and being earning that CDCES credential and maintaining it is about that, right? Is about a statement that says to the person in front of us, I'm not looking at just your glucose. I'm looking at all those factors, and whatever diabetes or glucose challenges you have, I can help you address those. And I have the training to do that.
Yeah, I started off in a primary care setting. I imagine similar to Jennifer to what you were doing. And I was also pretty much every patient had diabetes, and I had a huge interest in diabetes, but I wasn't sure I could become a diabetes educator because it just seemed like this elusive thing. Like, you need all these hours. Could I get the hours? Could I do the things? Like, the other pharmacists didn't have it at the time. And I learned more about it. And I said, you know what? I really let me see if I can do this. And some of the other pharmacists on our team also went ahead and pursued it. And I feel like I gained so much even in the studying for the exam. And I have no doubt that what helped me get my current position at Cleveland Clinic working in a diabetes center was that I did obtain my CDE, which is now the CDCES, because that shows this higher level of expertise. Like, I trained, I passed this exam, I have this specialized knowledge. And so I have found this credential to be so valuable throughout my career.
And where the CDCES, we think about the education of the patient first and foremost, I think that we need to also focus on that we are teaching providers. We are teaching the team. We're bringing that information out so that other providers can have the excellence in care that we all have with our certification.
I agree. And I have a story from a week or two ago. I had no groceries in my house. I was going to pick up a sandwich at a local restaurant, and I ran into one of my patients in the community. I knew she lived, in my area, and she was at the store next door, and she was like, "Come on in, like, look at all these plants. I know I always show you my plants when I come into appointments." And she introduced me to the lady at the cash register, and she said, "This is Katelyn. This is my diabetes educator." And I kind of paused and I was like, wow, I don't know that sometimes patients realize that title or that role, but it just was so special to me that she introduced me as that. She felt that we've built this relationship. And I think that's part of the journey, as we mentioned earlier, that it doesn't go away. And so we're going to be with them through whatever kind of life comes up and support these patients and educate in different aspects of their life as they go through different transitions of care. And so it was really special for her, or for me, to hear her introduce me as that, because I think sometimes it's like, oh, the pharmacist or the nurse, and so they kind of really identified me in that space of their diabetes care team.
Diana, you have built an entire diabetes technology education and training program at Cleveland Clinic. Can you walk us through what a day in your role looks like and where you most frequently intersect with other members of the care team?
So thanks for the question. I am going to pause for a second and say that I work with an incredible team, and Cleveland Clinic was thriving before I got there and will continue to thrive after I leave. But I've been fortunate to be involved in some great initiatives that I think have hopefully really helped our patients. So one of them that I want to describe is our diabetes and pregnancy program. And so we offer a clinic for people with pre-existing diabetes, like type 1 or type 2. And in this model, we do basically like a 3-part appointment that every person meets with a dietitian to really get education on healthy eating throughout pregnancy. They meet with a pharmacist where they get education. Often it's introducing new technology, seeing if they maybe will start CGM or start an insulin pump, or sometimes it's just insulin, injection technique. And then they meet with the maternal fetal medicine specialist. And we are very collaborative in this setting. Like, we're all talking to each other after we've met with the patient and really forming our plan together. And then we also have where we do a shared medical appointment for gestational diabetes. So this is more being diagnosed during the pregnancy. And this is also done collaboratively with the dietitian, pharmacist, and maternal fetal medicine provider, which either could be a nurse practitioner or a physician. And here we are all together. We are providing education throughout this pretty long appointment. It's 2 to 3 hours. And then the maternal fetal medicine provider is taking each patient out for a one-on-one individual appointment during that. So that's just like a taste of some of the kind of team-based care that we provide.
That's spectacular. Let me open this up to the group. Does anyone want to share any of the things they're doing?
One of the things that we're doing in our clinical practice here is we do an insulin pump class. So once someone once someone has started on an insulin pump, their first follow-up first they speak with pharmacy, by the way, and our pharmacists are helping titrate their insulin between the time they start their insulin pump and the time they come to follow-up insulin pump class. What we do at follow-up insulin pump class, which does involve a pharmacist, it does involve a nurse educator, and then one of the NPs in our practice, is that we then review what patterns look like as a group and help each other identify those patterns, each patient as a group. It's a really nice collaboration, and beforehand we can talk to the pharmacists and we communicate with them and say, okay, how's it gone in the last month or so? Are they bolusing? What are their biggest challenges? What is their biggest success? And a lot of times we start with, this person started with a time in range of 23% and now they're at 72%, or this person was having, significant hypoglycemia and now it's all gone. And so we always start with that celebration of the patient success stories. And it has been a wonderful collaboration at our practice. And we are about to move it. We started physically doing them and said, we just can't handle virtual. We just can't handle it. And recently one of our pharmacists said, come on, Natalie, we got to do this the right way. And so now we're offering our rural population options to be seen virtually.
Wow, that's amazing. I loved hearing both of those stories. And I think, what that tells us that is that, patient care and technology in this new program you're rolling out really works best when every member of that team understands their role and is part of that. So pharmacists and educators and nurses and nurse practitioners, physicians, advanced practice providers. So everyone contributes different expertise that ultimately improves patient outcomes. Wow, really amazing.
And I love the groups as well because they can have peer support and learn from each other, which is really special. I'd like to turn my next question to Natalie. As a nurse practitioner and a person living with type 1 diabetes, we'd love to hear about your dual perspective, both as a clinician and an individual with diabetes, which may not be on every care team. How is your lived experience shaping how you approach your role and the way you collaborate with pharmacists, endocrinologists, and other members of the care team?
Wow, that's a big question, isn't it?
Mm.
So I think the biggest thing is in having had type 1 diabetes for more than 50 years now, I think when you think back to the beginning and, in a generation, we have gone from urine testing to continuous glucose monitors to now automated insulin delivery to, the next, using adjunctive therapies to treat type 1 diabetes, all in my lifetime. I think in the beginning, as a young adult, I think everyone thought that I should know, and no one ever taught me. And so it was one of those, like, you just assume that that person knows this because they've had diabetes for a while, or you assume that they did this, or you assume that. And I think when I, as a person with diabetes, walk into a room, I assume nothing. And I start with, where are we? What do you need? What are your biggest struggles? Because no one ever asked me that for years and years and years. They just assumed that I would be okay and assumed that I just wasn't or was doing whatever was supposed to be happening, with never let's take a step back and make sure we're all on the same page, even if we're in the same book. And so I think that has made a difference in my career, to say to someone, this isn't your fault. What are our goals? What are your goals? What are your biggest challenges? What can't you do, or do you feel like you can't do? And help someone get to the point where they feel heard, they feel seen, and that we're addressing their biggest needs at this visit, and develop a long-term relationship with that person of trust. Because I think a lot of it comes from, in the old days, we would threaten, if you're not going to do this, this is going to happen. And I was like, I could care less. I'm 16, right? So I think now, as educators, you would never say things like that, but we did. And I think that helps me make sure that I walk in with the right balance from the get-go. I think my team appreciates that I keep my type 1, honestly, not in front of everyone. I don't tell a lot of people in my practice because it's not about me, it's about them. It just informs my decision-making and my approach.
That's great advice. Do you have anything to share, Kristine? You also shared that you've been living with type 1
Yes.
diabetes.
So I echo everything Natalie just said. I had a little bit of a different experience at the point of diagnosis. I had a lot of education and support. So as I am going in to see a person with diabetes, I also don't assume anything. And I've learned over the years that you can't assume anything. You have to ask, what is their health goal? It is always disappointing and startling to me when people say, nobody ever told me that. Or finding out that this person has had diabetes and thought they had, borderline diabetes. So bringing the dual perspective in, I think, grounds my practice. I do tell people I have diabetes. I sometimes I wait and use it at the appropriate time. If somebody, no one understands, or et cetera, I will make sure I tell them, because that is supportive to them and they're always appreciative of that. Bringing my experience to my nurse practitioner role, again, same as Natalie, it helps me with developing a plan moving forward for this person, not at this person. We're not threatening, we're not telling, we're doing this as a mutual agreement.
Yeah, it's you both had very different kind of experiences that you just shared, but I think, the big picture is patients don't experience healthcare in like silos. They experience one healthcare system, and collaboration should feel seamless for that patient. And it sounds like, this whole panel, but the two of you just spoke, really make sure that that's the experience that patients have. So with that being said, while I still have you, Kristine, I'm gonna keep you talking for a minute. And, you have this breadth of experience that you just told us about throughout this. And when you're thinking about nurses, nurse practitioners, and how do they fit critically within that interdisciplinary team? Where's the handoffs between the disciplines? So talk a little bit more about that and where nurses and nurse practitioners can fit into this big picture.
Well, I think that nurses, nurse practitioners have a background of fully assessing a patient. I think that that really is not unique to the team members, but it really does lend a lot of information to the whole team to help make the decisions appropriately for the patient. Um, I have been precepting nurse practitioners for close to 20 years. They don't learn enough about diabetes in school. Physicians don't learn enough about diabetes in school. So as I'm teaching them about the clinical skills, I'm also teaching them, how do you communicate with the rest of the team? How do you do that? How can we prevent the lack of communication or pitfalls of communication? In my role, as I've worked in outpatient and inpatient, and now I transcend both. I want to make sure that the team is aware of how to move the patient from acute care to community care. Some of the pitfalls of that is the discharge planning. People are at their highest vulnerability 30 days after discharge, especially people with diabetes, because so many things have changed. So many things are new to their treatment program. As the person comes in to see me in transitional care, and I'm giving the clinical care, our pharmacist helps with prior authorizations, assessment of potential interactions of the new medications, etc. So having a clear diagnosis, treatment plan, and then future plan, I think, is critical. And nurse practitioners and nurses, who are very often the front line to seeing that patient for the first time, can lead that.
Excellent. I wish everyone had one, just like I wish everyone had their own pharmacist on their team too. But certainly, uh, what I'm hearing you say is about bridging the diagnosis and treatment and education and ongoing follow-up care. So strong communications even during the transitions of care, and that a lot of really big gains can be had during that time.
And kind of wrapping up this section, I think that brings up some great points around communication and handoff. So, Diana, how do you use your roles to synergize your skills and expertise across the multidisciplinary care team, taking care of patients, and how do you streamline that communication across the care team?
Yeah, I think it's all about, every clinic or health system can be a little bit different in terms of people's roles. I know when I came here 10 years ago, I just did a lot of observing, listening to see what our existing diabetes educators, now diabetes care and education specialists, were doing so that I could be complementary and not overlapping, right? I asked our nurse practitioners, where do you guys need the most help? I asked our endocrinologists. And so kind of through that, I figured out where I could bridge the gap. And some of the things I've been able to help with, for example, are like post kidney transplant insulin adjustments. So people are discharged on these high dose steroids, and it was taking too long to get in to be seen by someone. And that was an area I was able to help with. And in fact, now I go directly to the kidney transplant clinic. I meet the patients where they already are instead of asking them to go to one other place. But it was really through talking to the other team members to find out, okay, what are you doing and how can I be helpful? In our practice, our diabetes, like our nurse and dietitian, diabetes care and education specialists, they can adjust insulin pump settings immediately after starting someone on a pump, like those first kind of 2 to 4 weeks. And then after, they don't do that. So that has become a really nice warm handoff now where the pharmacist can continue making those adjustments. So I think it's all about like figuring out what is in place and then how we can all work together for the optimal outcomes of our patients.
Absolutely. And I think that's great that you're able to kind of go into other clinics and help manage diabetes within those spaces, and meeting the patient where they're at, because reducing barriers to care is so essential, especially in that window. Like Kristine said, that 30-day post discharge, a lot can happen. And so that's great that you can bridge that gap as well outside of your actual endocrine space or endocrine clinic.
I think that, that shared documentation and then everyone on that team knowing exactly what their role is, what they're going to do. So it's everyone has a job as part of that, care for that patient, and then collaborative practice agreements for pharmacists, regular communication with the team, it sounds like, and then that mutual respect amongst the team members that allows everyone to practice at the top of their license makes such a big difference. Everyone owns the patient. Everyone's responsible for it, not one single person.
And also that way, if something falls through the cracks, someone else is there to pick it right up. Like, we're all human, right? Like, something, happens in that way, nothing gets missed because we're all working together as a team.
Excellent. Let's talk a little bit about technology, everybody. So CGM, automated insulin delivery, connected apps, remote monitoring. Diana, you lead education and training in diabetes technology at major academic medical center. We know that. So why don't we start with you? In your experience, who on the care team is best positioned to be the technology translator, the person who actually helps patients live with these tools day to day? And I think I can anticipate what you're going to say.
Well, yeah, because I worked with ADCES on this paper about the DCES being the technology champion, right? Because technology has evolved where, gosh, we have so many choices, so many different insulin pumps and algorithms and kind of nuances between systems that it is really hard for people to keep up with all of that. And I really feel that the DCES is like the person that can own this space and say, all right, like, I can do this. I can keep up with this, and then help everyone else on the team, keep them updated on what is happening, and then especially help our patients to make the most informed choices on what's going to be the best technology. And this is something that changes, right? It's not like you set it and forget it, don't come back to it. No, like, we should be, constantly asking, is this still working for you? How are you doing with it? Should we revisit other options? And then also the whole optimization of the device. I mean, any device can work well or not work well, depending on the education and training someone gets and depending on the settings that you have. And so the DCS can work to really set optimal alerts, set optimal settings to make sure someone really has the best experience with that, and then collaborate going through the data, really discussing that human connection of it. That what is the story behind these numbers, right? Like, anyone can look at this and say, oh, your time in range is this, but right, there's a story behind that. And the DCS is the one that typically has the time to ask the person, what is your story?
Natalie, what goes on where you are in terms of owning the technology and translating the technology?
So I think it is similar, and yet we have collaborative practice agreements with our pharmacists here, and they are we go back and forth. I mean, we have everything from the first time we had a new pharmacist start last year, and she came to me. She said, "So, do you mind if I change this rosuvastatin to atorvastatin? Their kidney function's declining since the last time you saw." And I looked at her. I said, "Never ask again. This is your job." Right? Your job is to help me help them preserve this. I'm glad you said it the first time. You have full authority. Go. Right? And she was like, okay. And then the next step was, because she's brand new, right? And then so the next step is the same. So I'd like to make these changes. Okay, are you asking or telling? Right? And really empowering each of us, like you had said before, Jennifer, of practicing at the top of our ability, right? And so sometimes it's I see a patient and I don't have another appointment available for 6 months. We can't leave someone for 6 months for a lot of this. So the pharmacists are doing as much and sometimes more than I am doing in between visits. They are helping we're a 403B hospital. They're helping with patient assistance programs. They are offering all kinds of other things that I can't do in my smaller time slot than they have. And so we rely heavily on each other. We had a recent person who was discharged we have a pharmacy discharge program where we actually have pharmacists that are in charge of managing the patient with diabetes, the person with diabetes, until they're seen again, either by endo or primary care. And our admission rates went down. This was read out at ADA last year. We're still working on the paper. It's coming, I promise you. And this is exclusively pharmacy led. They're running this. They're reducing our hospital admissions for us, reducing cost, improving time and range, reducing risk. It's amazing. And they're in charge and they're loving it. They're loving the independence, but they're also loving the outcomes. And the people are loving the outcomes because it's virtual. I think that one of the hardest things is asking a person with diabetes who also may have several other comorbidities. Go to this person, go to the kidney doctor, go to the heart doctor, go to this doctor, go to the podiatrist, go to the eye doctor, come see the dietitian. Do you want a psychologist? Great, come visit him or her as well. And they're like, wait a minute, all I do is go to a doctor and, oh, you need a job to have insurance. And so having our pharmacy team help with just one less thing where they have to walk out the door has made a huge difference and reduced our admissions significantly.
Oh, wow. Christina, you have something to add?
I work on a much smaller scale than Natalie and Diana. We are in early days of creating our high-level diabetes program here at BW. And, you know, in the hospital, our CDCES is the person that identifies who should be on technology, who should be on some of the more, the newer medications, GLP-1s, et cetera. She will then go to the diabetes treatment team and say, listen, I put a sensor on a person. Here's why. Let's move them forward. So then, you know, the referrals are made to ensure that the sensor or technology, because we're not doing pumps here, but the technology is supported post-discharge. So then they will come to our specialty clinic and we will interpret the data. We will make sure that the prior authorizations in association with our pharmacist are approved, and make sure as we hand off to the next provider, say the primary care provider, we are documenting very clearly with, you know, the documents coming out, you know, what is the CGM patterns, such, et cetera, why we made the changes related to this, because many providers don't understand how to do this. They don't know, they don't have the time. So if they have that piece as to why this change was made and writing it out in detail, that right there will then help moving forward to support that patient. You know, are they having alarm fatigue? Are they just tired of having sticky stuff on them? Is it not sticky? All of these things that we support these patients with from door to door and then beyond. So I think that that's important. We need to remember that there are other providers outside of our interdisciplinary teams.
So it sounds like what I'm hearing is the best technology translator is the clinician who has both the expertise and the time to help that patient. And depending on the practice, that might be a pharmacist, a CDCES, a nurse practitioner, a physician. It's truly, again, the theme that we keep hearing. It's shared responsibility. Katelyn, you have done significant work expanding access to diabetes technologies at Boston Medical Center, which is the largest safety net hospital in New England. And that context, safety net, which is underserved populations, resource constraints, is very important. How does the interdisciplinary team model serve patients in lower resource settings, and where does it still fall short?
So I first started at Boston Medical Center in primary care, and I kind of walked into a role at the time when I started where CGM was also increasing. And we didn't really have any CGM workflow in place. And so I had the opportunity to kind of find that as like when like Diana said, I walked into a clinic, I saw that there was a need, and I developed CGM services and trained other pharmacists as they were onboarded, did in-services with nursing who handle some triage calls, like my sensor fell off, my skin's irritated, these alarms are going off, and really worked to develop a program. I'm now in adult endocrinology, and we're part of the T1D exchange. And so we have data around our technology use, and it's quite incredible being at a health safety net hospital. I believe 90% of our T1Ds use CGM. I believe it's like 45% of our T1Ds use AID. And we have all of our AID training is done in-house by our pump trainers that are CDCESs. So myself, a nurse practitioner, and 2 registered dietitians that are pump trainers, and a nurse that just started. And so I think with certain uh, health literacy, cultural, language, it can be really challenging to get individuals onboarded to technology. And the CDCES can get really creative with how we deliver that education, be it the groups that Natalie mentioned, or developing educational materials in an individual's language. Bringing people's family and caregivers into the education appointments can help with successful onboarding. But where there might be gaps, I think, are when we turn to pumps and using pumps in people who don't speak English as their primary language. There are not a lot of materials to educate individuals. And that could be, an area of concern to make sure that they understand how to do troubleshooting and how to use the devices. And so I think that's where we spend more time educating our patients, and it may be slower to get on a device, but we're still supporting them through that journey. And it's so great that we have, the nurse, pharmacist, and nurse practitioner, registered dietitian. So, a lot of patients, maybe don't carb count, but those that have interest can see the registered dietitian before starting the pump. And so we have a lot of expertise and various backgrounds that can help match the patient. And I think doing the pump training in-house can be, a resource limitation at other institutions. But in our patients who kind of value that close-knit relationship and a trusting, valuable, familiar face, that can be really helpful in getting someone to, get on technology. If we say, oh, we're going to set you up with this pump trainer you've never met from the company X, Y, and Z, they may be more hesitant to go to that appointment or join that video visit. And so I think the resources we have, we do video, but some patients aren't comfortable getting on a video call and they prefer to come in person. And so we kind of meet their educational needs and tailor that journey of getting on a CGM or a connected insulin pen or automated insulin delivery to their needs, where we know them and we've had that relationship built with their, different backgrounds. They may feel like there's a lot of mistrust in different, healthcare providers that they don't know, and that would be harder to kind of go into something new that's foreign to them. And so I think we've built a really trusting team in our endocrine clinic.
Yeah, technology can only reduce disparities if patients can actually access it. So, our roles in helping patients overcome insurance and cost and language and health literacy and training barriers. And it sounds like this is exactly what you're doing and you're involved in this system. Does anyone have anything to add or share?
I think a big part of it is, we all have a certain amount of time and we all are in these you've got this and then you've got this and then you've got this and then you've got a call and you've got 2 more patients. And that's our day for all of us, whether you're a pharmacist, a dietitian, a physician, a nurse practitioner, a physician associate, all of us. And I think what we, when you look at the care of someone with diabetes who is in front of you, is what are their needs? What are their goals? And which person in our team in that circle of care can best address it as quickly as possible so that we can jump on things when it's time. We can say, let's, I can start someone on a GLP-1 and the pharmacy team can titrate that. I don't need to do that. I can see another patient and do something different. I can start someone on GLP-1 and say, I really want you to take advantage of this. It's going to make you feel fuller sooner. Let's get you to the dietitian to help with weight loss, because what you told me was part of your goal was weight loss. Let's help you do and really help pick and choose with the person in front of us which services in our our circle are appropriate and at what time. But I think that's what we're all talking about doing, all at the same way, just a little differently in each role.
To add to that, in our system, we also have community health advocates or community health workers, and they are very involved in working with the patients with diabetes. Now, they may not be interpreting data or prescribing or something like that, but they're there to support the patient in ensuring that they have ongoing health care, ensuring that they have the affordability for their medications. And that group of people can also be DCES or a certain certificate in diabetes specialty. And I think that's another important role.
So I have really enjoyed today's discussion because, you know, one message consistently has come through, and the future of diabetes care isn't about one profession doing more. It's about every profession, you know, working together, whether talking about technology or medications or education or improving health equity. So the best patient outcomes come when every member of the interdisciplinary team contributes. So with that, Kristine, you have any last words for listeners?
I think that anybody who is in healthcare should consider learning more about diabetes care. Again, we don't get enough in school, but also do it. Don't sit back and think about it. Go get your certification. Go take some education classes. ADCES offers so much education to add to your specialty. Step forward and advocate for your patients.
Katelyn, any last words?
It's been great co-moderating and hearing from each of you and how your practice is similar but different. And I hear what Jennifer said. It's that interdisciplinary model. It doesn't have to be any one clinician that is the tech champion, whoever is ready to step up and help the patients, whether that is a pharmacist as the medication expert or a nurse who's available to do a CGM teaching at discharge. We're all important to the journey that people are living with diabetes. And I agree with Kristine that ADCS has been an incredible resource for me. It's where I've met most of you and heard most of you present or had the opportunity to present with all of you and learn from other DCESs across the country and gain a lot of information. And I'm looking forward to the upcoming annual conference in Ohio this year.
Natalie?
I think the biggest thing is that it's not a stagnant disease anymore. It used to be for years. You guys, I was like, could we do something besides metformin and insulin or some sulfonylurea? Now, every week there's something new, and it's exciting and it's fun, and you change lives. When you manage diabetes, you're changing someone's outcomes, and that to me is everything. I want to work in an area where it's exciting, there's things happening all the time, and that we see amazing outcomes. And that's what working in diabetes in general does. ADCS has been an amazing support, and we've loved working with them, with our pharmacy team, with our NPs, PAs, physicians, everyone, to bring that to fruition and help people thrive.
Diana?
Yeah, so I think we just need all hands on deck. I mean, the latest stats are over 14% of US adults live with diabetes, another 38% have prediabetes. So we need all hands on deck. And you heard some examples today of how we do it in our practices. It may be different in yours, but I encourage you to reflect on the resources you have and really think how you can work together with your other team members to improve the lives of all the people out there that have diabetes or are at risk of diabetes.
I'd like to sincerely thank Katelyn for, you know, co-moderating with me and our outstanding panelists and our partners at ADCES and Pharmacy Times for bringing together this important conversation. So thank you to everyone watching. We hope today's discussion inspires you to continue building strong teams, embracing innovation, and most importantly, improving the lives of people living with diabetes.